All right, so let's get started with our next session, using data to protect beneficiaries and evaluate public health policies. And just as a reminder, please put your questions in the chat to be answered during the Q&A portion at the end of today's call. So we do have two data scientists on with us today as our speakers. One of them, Andrew Yaspin, was unable to attend, so he did record his portion. We do have Douglas Block with us today, so welcome, Douglas. I'm going to turn it over to you to kick things off for us.
Thanks, Rachel. Yeah, that's just said, my name's Douglas Block. I've worked been with CMS for about 3 years, and prior to that, was at the University of Chicago doing research there. And so what we're going to go through today is two presentations, and both of these presentations are designed to kind of show how we can use data to address important health problems that affect CMS beneficiaries, and then also evaluate the impact that public health policies have on beneficiaries in a really systematic manner to try to draw conclusions so that we can learn lessons from what we've done in the past and then maybe use that going forward. So with that said, can we move to the next slide, please? All right, so there's going to be 4 learning objectives. So, through both these presentations, we're going to be following the journey from a policy-related question, looking at how we prepare the data and then use that data to answer a question and or build an action. We're also going to highlight some of the challenges of using data, as many of y'all are probably familiar with if you've worked with CMS or CCSQ data. We have some really excellent data. There's also some issues that we have to address before using it. You can't just pull it out of the box a lot of the times. The other thing we want to show too in this thing is basically the power of our data set. We know that we collect a lot of data, probably have more data on healthcare than any other place, definitely in the US, maybe even the world. And we want to show what can happen when we use this data and bring data from multiple sources together. And then as mentioned earlier, we want to see how we can use this data to systematically evaluate public health policies. Next slide, please. All right. So this presentation, identifying potentially inappropriate diagnoses and prescribing in nursing home, is going to be the video by Andrew Yaspin. So I will go ahead and turn that back over to Rachel to start the video. Thank you.
Hello, good afternoon. My name is Andrew Yaspin. I apologize for not being with you to give this presentation in real time, but I'm glad I was able to have this recording shared with you. I will be presenting on some work that was born out of renewed attention on the long-standing issue of overprescribing of antipsychotics at skilled nursing facilities or nursing homes that evolved into a question on the feasibility of observing a particular presentation of the issue entailing additional dishonest practices by facilities using CMS data, and ultimately to an objective of targeting Medicare beneficiary patient records for review by the VFCCQIOs, leading to a recommendation by the Division of Beneficiary Reviews and Care Management on actions the agency can make to curb the practices. I'll do my best to explain the parties directly involved in this approach as I go. This is recorded, but I'm going to try and make this as smooth as possible. CMS has been involved in efforts to curb improper and overprescribing of antipsychotics at nursing homes for many years. The key concern is that antipsychotics can increase the risk and onset of death for beneficiaries with dementia. Investigations and reports looking at data from as far back as 2007 have noted years-long trends of significantly larger volumes of nursing home residents receiving antipsychotics than expected, as well as frequently dangerous uses of drugs based on box label warning labels. This led to an initial round of CMS survey and certification authorities being used to determine nursing homes' compliance with unnecessary drug requirement, and subsequently what sort of penalty nursing homes would get if non-compliance was found. More recently, renewed attention has been given to this issue and some specific versions of it since the publication of articles in the New York Times written in September of last year, highlighting a new finding that an increasing proportion of Medicare residents have schizophrenia, many of whom had no prior evidence of having been diagnosed before their stay. Schizophrenia is nearly always diagnosed before 40, well before an elderly beneficiary enters a nursing home. This is related to the overprescription of antipsychotics by way of what I just mentioned. Survey and certification groups, as well as other components, began using proportion of beneficiaries prescribed antipsychotics as a factor that could lead to a lower nursing home star rating. A diagnosis of schizophrenia excludes a resident from the numerator of residents on antipsychotics, which positively impacts their star rating.
I don't think so.
The article highlights the share of residents with schizophrenia diagnosis has increased 70% since 2021. And again, that antipsychotic medications, while potentially effective for treating certain mental health conditions, can have life-shortening adverse effects. Also mentioned, an OIG investigation found that 1/3 of long-term nursing home residents received schizophrenia diagnosis in 2018. There was also an article in the New York Times highlighting that the practice disproportionately impacts Black nursing home residents. So it is an equity issue. So CCSQ wanted to use this renewed interest to think a bit differently and use our own data to answer some of the questions that could lead us to potential interventions. The overarching motivation or question was, which nursing homes have a history of or continue to use antipsychotics inappropriately? So we're trying to look at the facility level, but also the beneficiary level for residents with no underlying clinical indication, such as an existing psychotic disorder. And the key piece, to what extent can MDS documented diagnoses be validated by administrative claims? So this is where we get into what data do we have? Does it have the detail we need to be able to transform records into the right normalized base sets to answer some questions? So, don't get too lost in this slide, but an overview. Given our new approach, we engaged with other components of CMS and the Department of Justice to understand the various levers available to us to address issues of overprescribing and fraudulent diagnosis, as well as how we may design an analysis that would inform decisions on which option is most sensible and how it would be leveraged. The one that we will focus on later is the Division of Beneficiary Review and Care Management, Beneficiary and Family-Centered Care related focused review pathway. So this is basically allowing the BFCC QIOs who we contract for a lot of due process rights for beneficiaries as far as the quality of their stay, being able to do in-depth reviews of beneficiary medical records to make some determinations and then provide us some summary analysis so that we can take further action against facilities that might be heavily in violation of laws. So in order to prepare this work, we wanted to try and keep the data analysis piece to figure out who to focus on, which beneficiaries in-house, and then provide referrals to the BFCC QIOs to greatly reduce the amount of work they had to do, and also have a better understanding that we could share internally for how we did this work. There will be more explanation on the process and some of the documentation created in the process that I would like to make available to build on. As far as where the data is, we began this work knowing that I would have access to MDS, National Claims History data for Parts A and B, and then Part D drug event data. I then needed to identify where and how I could access this data. It took some asking around and perusing the data catalog, but ultimately I was able to find out how to identify and access these data, as well as the additional data that I'll mention later that I use to further enrich the base data sets we were looking at and provide some interesting stratifications for exploratory and summary analysis. So there's some documentation available via the data catalog, but oftentimes documentation required to understand what a given column table or table column contains, or what parameters define a unique event or row in a table is not. And so one must set out on a search to further decipher what it is they are looking at. In my case, I found information useful for my understanding from documentation on medicare.data.gov, the CCW website, and user manuals found via Confluent or offline conversations. There were some additional challenges to this, including mapping differently named columns between two locations where the same data is hosted and language requiring inferences for how to minimize the inclusion of edited information or updated, not necessarily representative information. So I will get into a little bit, but basically I first created a transform pipeline to create base tables and perform some exploratory and summary analysis in Zeppelin. Upon having access to Databricks, I moved the work over to that platform. And finally, I adapted the scripts to a DBT workflow so that I could rerun any of the portions of my pipeline via the command line and take advantage of documentation pages that accompany the DBT build process. This allows me to share what I learned, open it up to scrutiny, and enable others to build off of it. The process of identifying data, documentation, and where to write skips to prepare for and perform analysis required various iterations and toggling between each step. So ultimately, I ended up supplementing the MDS and NCH claims data with nursing home compare data, beneficiary in the cloud data, MDM data, and the FDA drug list data. In order to develop the base tables, we needed to figure out who we're focusing on to develop the high-level aggregate numbers to then figure out how many referrals we'd be able to make. Basically, how many people were in the original cohort that we would subset in order to take further action on. And how could we get a good global understanding of the issue within a static period of relatively static set of data, but also in a static period of time, so that we could feel confident about any analyses and inferences we were taking away from the work. So we decided to include fee-for-service beneficiaries, or they were fee-for-service beneficiaries prior to entering the nursing home. They had to have an admission between January 1st, 2020 and June 1st, 2021, and they had to have at least one quarterly or non-admission MDS assessment. It could have been quarterly or annual. This would include any long stay beneficiary and short stay assessments. They weren't distinguished between. So a note, the nursing home staff filling out MDS forms don't distinguish between schizophrenia, schizophreniform, or schizoaffective disorder, and they seem to all be used similarly when counting beneficiaries in the numerator of those who are prescribed antipsychotics, or in the case of the people who were given a positive indication for schizophrenia or any of these terms, not counted in the numerator, but counted in the denominator. This is just a high-level image of sort of how we brought the data together. There's also a prescriber level data set, and looking at the prescription side of things, there were a set of post and pre nursing home admission prescription tables that we also created. So part of the process was normalizing the assessment to a stay level and then aggregating to the beneficiary level, the facility level, and the state level, doing similar process for claims and creating tables that existed at the same sort of object orientation. We then joined the data to answer questions about relationships between and amongst the levels. We created dummy variables to easily identify and stratify beneficiaries by diagnosis and conditions, as well as demographics. We supplemented the data with nursing home compare and FDA drug list data. In the process, we used different ways of exploring the data, pre and post stay, prescription and diagnosis events. So an intermediate product that we created was a ranked list of the top 10 nursing homes in terms of their violation of, or actually amongst those who have the greatest number of beneficiaries diagnosed with schizophrenia. And this also just shows how there was variance in the percent of unsubstantiated cases of beneficiaries who had a positive indicator for schizophrenia. Again, unsubstantiated means there wasn't evidence in the last 5 years of a Part A or B Medicare claim with that diagnosis of schizophrenia, schizophreniform, or schizoaffective that would have been positively indicated in MDS assessments. So the next step kind of provided the ability both to refer specific beneficiary cases to the BFCC QIOs, as well as a way to validate the work that we did, because with these medical reviews, they would actually be collecting patient records and looking to see if there were any diagnoses that could have validated the MDS noted diagnoses. So just a bit of background, BFCC QIOs have the authority to request medical records for focus reviews that are requested by CMS. For budgetary reasons, each BFCC QIO, and there are 2, can review records for up to 50 beneficiaries. They over request, but then they don't get records for everyone, so they have some number around below 100 reviews. And then just some high-level information on the cohort. A more recent run of the pipeline yielded 13,882 beneficiaries with potentially unsubstantiated diagnosis of schizophrenia. So we had to narrow that down to a much smaller number for the BFCC QIOs to be able to select from. Didn't have to be 100 exactly. We wanted them to be able to consider some aspects of facility geography and spread across the 2 BFCC QIOs as well. So we provided a list that was narrowed down based on the following. They had a first nursing home stay during our admission window because there were people who had a previous stay. They had an unsubstantiated diagnosis of schizophrenia, according to MDS. Their first evidence of an antipsychotic was after their entry to the nursing home. They had also been indicated as suffering from dementia, and that they were from a nursing home with at least 10 instances of unsubstantiated beneficiaries. Oh, there's a little typo there. So ultimately, that had us yield 343 beneficiaries that met this criteria. So now we are kind of months later, and the BFCC QIOs are reviewed and made determinations on if a standard of care was met on 2 key aspects of the case, actually 2 standards of care: if the diagnosis of schizophrenia was appropriate, and whether or not there is sufficient clinical basis for the prescription of antipsychotics. And 1 BFCC QIO reviewed records for 44 beneficiaries and the other 27 for a total of 71. So they provided their results both in a templated fashion that we provided a template from the Department of Justice. They filled out the questions so that we could get some information to, get both, validation of our method, as well as any additional insights that, could perhaps inform what actions we take or any further analysis. In most cases, there was no direct observation of the symptoms documented in the medical record that would support a diagnosis of schizophrenia. At times, the symptoms that a beneficiary exhibited allowed for the use of antipsychotic medication. So that is sort of harking back to the idea that antipsychotics could be prescribed on a special basis, but it needs to be validated by, clinical and expert opinion. Overall, in BFCC QIOs, 71 cases, a diagnosis of schizophrenia was noted in the records of 70 to 71 patients. That's 70 out of 71 patients. So our method was very valid in identifying people who had a diagnosis of schizophrenia and their MDS. Why there is discrepancy of 1, not exactly sure, but there is this piece of human error involved in entry, as well as records that were updated over time. And then of those 70 patients, a full 65 of them had no basis in medical record for the diagnosis of schizophrenia. So we found a lot of unsubstantiated diagnosis of schizophrenia. Some more information on whether or not the drugs met recognized standards of care. There were more cases that met recognized standards of care as it relates to administering an antipsychotic, which brings up more information, to consider as far as next steps. This, is to try and identify inappropriate use of antipsychotics. What we're also finding is that there was some cover up for appropriate uses. And was this, something that, we ought to consider as we think about star ratings. Something actually, if we go back, we notice just how many of the star ratings categories are lower for these facilities. So, most of the top 10 have lower star ratings, but there are, some in here with higher ones. So interesting associations. So as a result, 2 nursing homes are recommended for the BFCC QIO sanctions process because of a higher degree of their violation. So based on the reviews that were conducted at these facilities, and they tried to review at least 5 at each of these facilities. So there are 9 of them. 2 of them had sanctions for a higher degree of violation. 9 of them are being recommended to for a quality improvement initiative to the Quinn QIOs, and all of the nursing homes are being recommended for referral to QSOG because they added a diagnosis of schizophrenia without documenting necessary details. So thinking of it as a coding error as well. We also found that the actual diagnoses according to patient records from the nursing homes was schizoaffective disorder for 82% of the beneficiaries. So this is not schizophrenia. But there were also 34% that had schizophrenia. Yes, there was an overlap, and 1% who had schizophreniform diagnosis. In 76% of the cases, there was aggression towards others at the facility. There was variability in the use of psychology evaluations, and this could have also been related to the way that the BFCC QIOs did their review if they were looking for certain things. 63%. Sorry, that's a typo. Sorry, this is 63%. How was it? No, all of them had dementia. So just forget that one. 34% had noted falls. And there were some more findings too that based on a analysis that I did after reviewing each one of the reviews and noting themes. So overall, we're at a state where we're making recommendations, we're looking further into the issue. One of the key, pieces here is that using claims in combination with MDS is more powerful than using either alone. We're using, CMS data in-house. We did a lot of the analysis work, a lot of the heavy lifting, and we used the partnership of our BFCC QIOs appropriately. This approach identifies potentially unsubstantiated diagnosis using administrative data. Clinical verification still is needed, and we got it. And so that provided validation to our methods, which is promising. It kind of gives you a sense of like what we're capable of. And I'll skip this last bullet and mention that, part of this, I didn't have many snapshots of the work that I did here. I figured this would be more of a motivation for more in-house analyses and using more CMS data. But one of the things that we really tried to do here is document our methods, and we're continuously experimenting with and trying to improve how we share that out and build upon it. We want to reduce redundant efforts as much as possible and have valid ways of building off of prior analysis and institutional knowledge. So I think I ran a little bit over. Thank you very much for your time. Have a good day. Bye.
So Andrew isn't here, but thanks so much for him. I encourage y'all to reach out. He did a really great job with this project, and as you saw, the results are very interesting. So what I want to talk about now is another way that we used CMS data to evaluate the impact of state COVID-19 vaccine mandates. And, I'm sure many of y'all are familiar with these mandates, have been in the news a lot, and particularly when it comes to nursing homes. And I think a lot of the reason nursing homes have been in focus because the high toll that COVID had on them. So the most recent data shows that about 159,000 nursing home residents have died from COVID-19 since the start of the pandemic. So what we wanted to understand was, how did these state COVID-19 vaccine mandates influence a number of different things. So the first one is nursing home staff behavior, resident care, and then resident COVID-19 outcomes, which we're defining here as COVID case and death rates. And this project started about a year ago when we were looking around at the news, and it saw a lot of stories that came out looking at these mandates and said this is going to be a disaster for nursing homes because everyone's going to leave the nursing home, employees are against it, and there'll be a resident care crisis. In other words, we won't have enough nurses and CNAs and LPNs to take care of the residents. And as you see from these headlines, these are just two headlines. I'm sure you could find probably a couple dozen more. Time Magazine was discussing it, the AARP. I think there's stuff in New York Times, Washington Post, and a variety of other local sources. Next slide, please. And so rather than waiting for the end to tell you all the punchline, I'll go ahead and tell you what we found here, and then I'll walk through the process of how we went about finding these results. So we found four main things in this project. So the first was, as many of y'all may expect, the state vaccine mandates were associated with a large increase in staff vaccination rates, but only when they did not allow the employees to opt out through regular testing. And I'll discuss later on a little bit more what that means. Second, contrary to what a lot of people thought, we actually didn't find any evidence that the mandates led to increased staff turnover. And relatedly, there wasn't a decline in clinical care hours. In other words, these unexpected or kind of negative consequences of the mandates did not bear out based on our analysis. And then finally, one finding, which was a little bit surprising though, was we also didn't find any relationship between state vaccine mandates and resident COVID-19 case or death rates, either positive or negative. And again, I'll discuss a little bit more why we think that's the case later in the presentation. Next slide, please. All right, so the first thing is, when we started this project, we looked around in CMS and then also outside CMS, and we couldn't actually find any information on state vaccine mandates, so we just went and built it ourselves. It took about 2 or 3 days, and we basically looked at all 50 states in Washington, D.C., and we asked the question, did they have a mandate issued by the government? So this could either be the governor or the health department. And if they did have a mandate requiring nursing home staff to be vaccinated, could employees opt out without needing a religious or medical exemption? In other words, were people given the option to say, I don't want to get the vaccine, but I'm willing to be tested 2 or 3 times a week, so I don't need to get it. And what we found was that 10 states in Washington, D.C. issued a mandate that did not allow the vaccine to be opted out unless you had that religious or medical exemption. And those are primarily in the Northeast and then the West Coast, as you see from those darker colors. And then we had 5 states that did allow you to opt out through regular testing, Mississippi, Illinois, Washington, D.C., and then here in Maryland, where CMS is our primary office is, as well as Delaware. And then there's 35 states that had absolutely no mandate. And so this provided a nice experiment because you have some people getting one type of treatment, another group getting another type of treatment, and then a third group that had no treatment or no mandate. Next slide, please. All right. And so we looked at 4 outcomes. So just to make sure everybody's on the same page, we defined staff vaccination rate as basically the percentage of healthcare staff that are fully, partially vaccinated against COVID-19. We didn't include all nursing home staff because that data actually doesn't exist. The data that's collected by the CDC only focuses on healthcare staff. We also looked at staff turnover rate, and what we looked at is basically the question of among healthcare staff, so RNs, LPNs, and CNAs, what percentage worked in one 60-day period also worked in another 60-day period. For resident care hours, we just looked at the average hours that each resident had of care from each of these 3 groups of clinicians. And then finally, for resident case and death rates, we looked at the rate per 100 resident weeks. And we used kind of a rate rather than a raw number because nursing homes vary in size from 50 to 1,000. So you don't want to be comparing a nursing home with 1,000 residents to one with 50. So this kind of puts everyone on equal footing. Our primary predictor is whether the state had that mandate, and then again, whether the state could, or whether staff could opt out of that mandate through regular testing without that religious or medical exemption. We also included a bunch of other metrics in the model. We included the county unemployment rate, because obviously if you're working in a nursing home, if you don't want to get vaccinated, you're going to want to know what other job opportunities there are. So that's likely to influence your behavior. We also looked at some state COVID metrics, particularly, the overall case and death rate for residents. It gives us general patterns for COVID at that time, as well as the vaccination rate for adults in each state. And then we included several nursing home metrics, including their overall survey score on the health survey, the number of violations, whether they were for-profit and they're in their overall size, or the number of beds that the nursing homes had. Next slide, please. And so as you see, there's a variety of metrics, and we pulled these from a bunch of different sources. So here on the left, we have two sources that are actually within CMS, which is Nursing Home Compare, and then the payroll-based journal. Nursing Home Compare contains a lot of just statistics about nursing homes, the health inspections, violations, et cetera. And then the payroll-based journal is a really amazing database that basically documents, it gives each nursing home employee a unique ID, but you know what nursing homes they work at, and then the number of hours they work on each day. So you are able to track down to an individual employee level how many hours they're working and whether or not they worked in different periods. But we also needed to pull some data from outside sources. So for data on nursing home vaccination rates and nursing home deaths, we have the NHSN, which is a CDC database that CMS has access to. We use it on our web page that looks at like COVID's impact in nursing homes. We pulled data from the Census Bureau and the Bureau of Labor Statistics. So what you see here is we used internal data and external data, and we brought it all together, which I think is a really important thing, because that's what we want for government. Like, you're able to pull everything, everyone's work, to answer one question. Next slide, please. All right. Now, we wanted to do a more inferential statistical approach, as opposed to just kind of a general view. And so what we did was an approach that's called difference in difference. And basically what this means is you compare the change for each of these metrics in nursing homes that were subject to mandates to nursing homes that were not subject to mandates. And you look at what happened before the mandates went into effect versus where they were after the mandates went into effect. And that difference allows us to see the impact of these mandates. So for COVID case and death rates, we looked at 30 days prior to the mandate and then 30 days after. And we chose the 30 days prior because most states that had mandates gave employees about 30 days on average to get vaccinated. For the vaccination rate outcome, we again used that 30 days prior, but for this one, we actually looked at the week the mandate went into effect, because all these mandates required by a certain date you had to get vaccinated, or you were either suspended or were fired from your job, or the nursing home would get a large fine. And then for turnover rates, we looked at 60 days averages, just to take into account that some people may not work every week or month. Some people may pick up a shift here or there. Some people may be on vacation. Some people may be sick. And so that, using that longer period of really allows us to see who left and who is still in the nursing home working there. Next slide, please. Now, with any statistical method, you really want to understand what are the assumptions that go in, because if the assumptions aren't met, the method is not going to work correctly. And so this method requires two assumptions, which we'll talk about. One is parallel trends, and the other is, in general, the more similarity you can have between each group, i.e. nursing homes that had a mandate and those that didn't, the more we can think that our results are generalizable. Next slide. Okay. And so for that first assumption, the parallel trends assumption, what that just means is for each of these three groups, the nursing homes that didn't have a mandate and then nursing homes that each had a mandate, all three of those groups, prior to any mandate being announced, they should be moving parallel the lines. They don't have to start at the same point, but in general, they should be moving at a similar level. And what you see here from this graph, if you look at the -90 to -30 on the x-axis, is that it looks like overall they really were moving at parallel levels. It's not a perfectly parallel, but it's pretty close. Next slide, please. And again, similarly, if you look at all these other metrics that we include in our model, They're not 100% the same, but they are similar across a variety of metrics ranging from case rates, facility size, for-profit status, et cetera, which gives us a little bit more confidence in our results being generalizable to a broader population. Next slide, please. Okay, so what do we find? So I'm not going to show you a bunch of statistical tables because I don't think that's very helpful, and it's also not easy to understand. So what I have here instead is graphs which provide that same information in another way. So what you have is two diamonds, one diamond each for each type of mandate. For the no opt-out mandates on top, and then the bottom is on the opt-out mandate. And along each of, or related to each of these diamonds, you see two lines. And what these are, these long lines, they're called confidence intervals, which basically means we can have 95% confidence in our results. And so if those lines cross that 0 line on your x-axis or your bottom axis, that means the results are statistically insignificant, which means we can't say there's a relationship. So as you can see from here, both metrics, they're on the positive side and they don't cross the 0 axis. The opt-out mandate, it looks like it does, but it's actually just to the right of it. And so what that means is these mandates had a positive impact on staff vaccination rates. Now, what you can see too, though, is that they look like they're at different points. And if we go to the next slide, we'll kind of illustrate the difference between them. So for the opt-out mandate, it looked like it had a much smaller effect. So if we go with the hypothetical case that there was no mandate implemented and the current vaccination rate just kept continuing at previous levels, we would have ended up with about 72% of staff vaccinated in states that had an opt-out mandate. But because there actually was a mandate, we ended up with 73%. On the other side, for the no opt-out mandate, we would have ended up with 84.5% of staff vaccinated. And with this mandate, with these mandates, we ended up with 91.1, right? So you see the effect is much larger for the no opt-out mandate. Next slide, please. And then when we get to staff turnover rate, remember I said if it crosses that 0 line, it means it's statistically insignificant, which means it doesn't have any discernible effect that we can find. And what we find is for every metric related to staff turnover rate, it passes through that line. In other words, we can't say that these mandates led to higher higher staff turnover rate for any type of clinical staff. Next slide, please. Again, we find something similar when it comes to resident care time, which is just the number of minutes of care that each resident receives from these different types of staff. 7 out of the 8 metrics are statistically insignificant. Now for the opt-out mandate, we do see for RN care, which is the blue one at the top, there's a small negative impact. It's about 36 seconds, but in terms of clinical terms, that's basically, in practical terms, it's insignificant. So statistically insignificant, or statistically significant, but practically insignificant. Next slide, please. And then we get to resident case and death rate. And here, again, we see that all the metrics go through the 0 line. And so what we have to say is that we could not detect an association between either type of mandate and changes in resident COVID-19 case rates or death rates. And we think one of the reasons why there is no effect of these mandates that we can detect is because you already had a really high rate of vaccination among nursing home residents, about 90% on average. And you also had a high vaccination rate among staff as well, even before the mandate. And so because a lot of these mandates went into effect after you have really high levels, having a few more people vaccinated actually doesn't seem to be related to like lower rates of problems for residents. Next slide, please. All right. And so I think there's a few key takeaways. So kind of going back to what we talked about in the beginning, these vaccine mandates are effective at increasing staff vaccination rates. We didn't find any association with these state mandates with changes in nursing home resident COVID-19 case or death rates. We also didn't find any association with these mandates with mass employee resignation, which was kind of the argument that was going on in the public sphere at the time, or a significant decline in resident care hours. Now, if we think moving just beyond the project, thinking more broadly to CMS or CCSQ in general, I think what we can say is that CMS slash CCSQ has a lot of data sources, has a lot of really interesting, rich data, and this provides us a way to really look at public health policies and analyze them systematically rather than using an anecdotal evidence from one place, one nursing home or one source. We can look at it using advanced statistical methods to really say, what do we find if we look at every place here? Second thing I would say is, a lot of times we may need to gather outside data. The data may not be typically, or I should say typically, is not just going to be in one data set, but even if it is, or it may not even be within CCSQ or CMS, it can be from a wide variety of places. And that's why we have multiple agencies collecting multiple data, both within HHS and outside of HHS. And so we can do this type of projects and really look at things, evaluate policies, and see what is best for residents and for the American people. Next slide. Happy to answer any questions. I see there's some in chat, but if anyone has any questions you want to come off speaker, feel free to as well.
Yeah, there was one question so far. One user asked, are these risks adjusted or unadjusted rates?
So they're adjusted in terms of we use a case rate per resident weeks. And so all the rates are for 100 resident weeks. So it's case rate adjusted if I understood that question correctly.
Okay, thank you. And there was one other question, but it was actually pertaining to Andrew's presentation. But I did see some great conversation that was occurring in the chat. But we will send that question also to Andrew after this presentation and make sure we get an answer and post on Confluence for everyone. And with that, I'm not seeing any other questions. So thank you so much, Doug, for coming on and sharing this. It's very, very fascinating. So now we're going to go on a 17-minute break. Our next session is going to be on the feedback analysis system. So at this time, let's go on a 17-minute break and we'll be back at the top of the hour.